Good afternoon, faith, friends, and family. We're here with our health series, knowing that health is wealth. And we are delighted to have with us today, speaking with us, Dr. Michael Ebright. Dr. Ebright is the Director of Thoracic Surgery and Vice Chair of the Department of Surgery at Stanford Hospital. He is an Associate Clinical Professor of Surgery at Columbia University Medical Center, and he is an attending surgeon at New York and Presbyterian Hospital. We are so glad to have you with us on today, Dr. Ebright.
Thank you so much for the invitation, Reverend Ford, and to speak before the Faith Tabernacle Missionary Baptist Church. I know that your attendance is tremendous here, with a lot of engagement, and I hope to live up to all of you, to hopefully get a message across that I think is important, and I'm actually quite passionate about. And that's to talk about cancer screening, but specifically lung cancer screening. And I'm going to tell you why. It's actually made a difference in a lot of people's lives. That saved many, 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 many lives. And I'm going to try to kind of, keep this. I think my time is about 20 minutes, but we can keep it kind of informal. So if Reverend Ford wants to interrupt me at any time, he is the boss and he can ask me whatever he wants. So I'm going to actually, so Reverend, if you wouldn't mind putting up the slides. Okay, perfect. That's great. So that's the title slide. We can go to the next one. I'm going to talk just, can I control this or do you control it?
You control the actual slideshow.
I control it. So if I go let's see.
So do this, Dr. Ebright. Go to slideshow up at the top. At the top, it says slideshow.
I'm looking. Oh, no. So I have to go on to the other. Hold on. I know what I need to do here. I go to here, and then I can go to slideshow. So if I move it here, does it move for you?
It does. Yes, sir.
Okay, then that's what I'm going to do. I can't see you or anybody else, but I can see my own slides. And I can actually make it. Does that make it better?
Yes, it does. Yes, sir.
All right, so there we go. Okay, so I'm going to start with a little bit of statistics because statistics are fun. But what I want to get across here is that lung cancer actually counts for the most cancer-related deaths in both men and women. And this is why it's important. So in men, people think prostate cancer. In women, people think breast cancer. And although prostate cancer is more common than lung cancer, and breast cancer is more common than lung cancer in women, lung cancer accounts for more deaths in both sexes. And so in 2025, that's an estimated 250,000 new cases and 125,000 new deaths in just 1 year, which is 20% of all cancer deaths due to single organ cancer. So that is a huge, huge number, which is why it's a major public health problem. And if we look at, now this is not necessarily a cheery subject, but death rates among men over the years, the death rates seem to have peaked at around 1990 of lung cancer. You see, I don't know if you can see my arrow when I'm doing this or not.
Yes, sir. Yes.
You can. Okay, so you see there was a peak in around the 90s of lung cancer. But you see here how much lung cancer dwarfs prostate cancer deaths, which is way down here, colon rectal, pancreas is way down here. So lung cancer is huge. Cancer death rates in women, similar. Lung cancer tended to peak actually around the mid-2000s as opposed to 1990s in men. Breast cancer, the death rate's actually decreasing a bit, but still obviously very important. Colorectal cancer's down here. But it is interesting insofar as the peak for lung cancer happened in women a little bit later than the cancer rates in men. That may be because smoking is the biggest risk factor for lung cancer, and there's about a latency period of about 3 decades. So 3 decades before, what were we seeing on TV and in the magazines? We were seeing this, right? So what we're seeing is those Virginia Slim ads were very, very effective. They depicted cigarettes as a mature, something that mature women do, that's glamorous and sexy, but this beautiful woman here in the ad, well, she's now traded her roller skates for a rolling walker. She now has coronary artery disease, peripheral vascular disease, and is probably coughing up a lung in a pulmonologist's office somewhere. Interestingly, lung cancer in China is also on the rise. And as that nation becomes further industrialized, there are more and more smokers. And 2 of every 3 Chinese men smoke, and 1 of every 4 deaths due to disease are due to lung cancer. 25% of deaths due to natural causes in China are for lung cancer. So this is just briefly showing what I already told you, is that in men, prostate cancer is the most common up here. These are estimated new cases. Prostate cancer accounts for 30% of new cases of cancer. In females, it's breast. But lung cancer in men is about 20% of cancer deaths. It's actually the same as prostate and colorectal combined. And in women, lung cancer is 21% of cancer deaths, which is sort of approximated by breast and pancreas cancers combined. So it's a big deal. Lung cancer is a huge public health problem. Not only that, it's a women's health problem.
Mm. So let me ask this, Dr. Ebright. So why is lung cancer usually more deadly than these other types of cancer that we may see?
Well, I love the fact that you asked that question, because it's really going to be important later in the talk, because of the importance of lung cancer screening. So the problem with lung cancer is that it doesn't cause any symptoms. You can't feel your lung. It's inside your chest. The lung has no nerve endings, so you can't feel pain from a lung cancer until it spreads. And it spreads to the bone or the brain or somewhere else where it's going to cause symptoms. And once lung cancer causes symptoms, it's usually much, much more difficult to treat and is a much higher stage. So at the time, like we always know with cancer, the earlier you find it, the better. But it's really difficult to find lung cancer early because it doesn't cause symptoms until it's very, very late. And that's the reason the death rates are so high for lung cancer. In breast, you can usually feel it. You can get a mammogram. In colon, you may have a little bit of blood. You may have some difference in your bowel habits. Prostate, it may be some issues with urinary retention or something else. But in lung cancer, you don't really get symptoms until it's way too late.
Wow. And so with it being you're not really realizing the symptoms, and I know you probably have this later on in your presentation. So what's the recommendation for testing then?
Yeah. So if you don't mind, I'm going to kind of skedaddle and get to that part. So
Okay.
we do have recommendations. That's actually the crux of what we're going to talk about today is why do we give those recommendations and who should get screened for lung cancer and who shouldn't get screened for lung cancer, quite frankly, because lung cancer screening even has its risk. So I'm going to accelerate a little bit. We're going to get to this. What I'm showing here is this is why it's important to discover lung cancer early. So we've all heard of lung cancer staging, and stage 1 is okay and stage 4 is really bad. These are survival curves, and what you see at the top is the survival rates for a stage 1 cancer are much, much better than a stage 4 cancer. So we want to catch the cancers when we can really treat them. And what we want to do, so interestingly here, in Reverend Ford, this is exactly why lung cancer causes more deaths, is because only about 15% of cases are discovered early with lung cancer. So in this pie graph we see over here, 15% of cases are discovered early. The rest are discovered late. So the 15% are the ones that we can cure much easily. So we want to increase this piece of the pie from 15%, maybe to double it to 30% or more, right? That's what we need to do. And that's why we need to screen. So let me talk about screening. So screening is interesting. Screening is something that we do for a normal population. We don't screen patients with symptoms. That's something called trying to get a diagnosis. Screening is to do something to look for something that's not causing any symptoms. And the goal is to benefit the population, right? We're going to benefit the entire population by screening. We got to weigh the risks to healthy individuals against the benefits found to have for those who have disease. So for instance, if let's say a woman goes to get breast cancer screening, they got to take time off of work. They got to drive to the mammography place. They have to undergo, from what I understand, a very unpleasant procedure. they're exposed to radiation, it causes anxiety, only to find that they don't have breast cancer. So how did we benefit that patient? That particular patient, we didn't benefit at all. We caused them a lot of heartache and grief, right? So it's the benefit of population, not necessarily the individual person. You can spin it however you want and say, well, that individual now knows they don't have cancer. They may have had cancer. They would have discovered early, but the goal is to benefit a population by decreasing the cancer death rate. And the value of screen is linked to those people. If you can target them, you don't want to screen everybody because then you'd be screening too many people to discover too few people that have a disease. And you also want to make sure you screen people where if you find a cancer, you can actually help them. We don't screen for pancreatic cancer because it's much more difficult to treat. And once it's found, there's not a lot oftentimes that we can do for it. So with lung cancer, we actually have very effective treatments. So this was studied, and it was studied with a massive national trial of 54,000 patients between the ages of 55 and 75, basically, who smoked a lot. They had to have smoked at least a pack a day for 30 years. And if you were an active smoker or quit within the past 15 years, you qualify. We'll get to this more later, but you qualify to be screened. And they basically either gave you a chest x-ray or a CAT scan. And they did it every year for 3 years. And then they followed those patients for a few years. And they wanted to compare. They already kind of knew that chest x-rays, which is just really looking for shadows, didn't really help that much to finding lung cancer. But CT scans, they hypothesized would really be helpful. And the results were published in our premier journal, the New England Journal of Medicine, in 2011. And it showed that chest CT scans found a hell of a lot more lung cancers, and it decreased the death rate from lung cancer for the patients that were screened. So it decreased the death rate from lung cancer by 20%, which is a really big number. And it decreased the reduction in overall mortality by 6%, so death of any cause. But the number to really focus on is something we talk about in screening called the number needed to screen to prevent one death. So you need to screen 320 patients to prevent one death due to lung cancer. So is that a big number or a small number? I'm going to leave it up to you, but I'm going to compare that number to what we do for other screening tests. And I'm going to skip this slide. But basically, lung cancer screening was picked up by a lot of national organizations saying, we got to start doing this right now. We got to start U.S. Preventive Task Force, Chest Physicians, American Society of Clinical Oncology, the American Association of Thoracic Surgeons, which is my organization, American Lung Association, American Cancer Association. They're all on board. And why is this? So for breast cancer, you need to screen 1,200 patients to save one life. For colon cancer screening, you need to screen almost 900 patients to save one life. For lung cancer screening, you only need to screen 320 patients to save one life. And that's actually only after 2 years of screening. Imagine if you screened, for a decade or more, you'd even screen, you'd be even preventing more deaths. So it's very, very compelling that we should be screening for lung cancer in the patients that qualify.
Yes.
So that you may wonder, well, why get screened, right? Why should we get screened? So we want to discover disease when it's treatable, and in lung cancer that means oftentimes curable. We need to understand that lung cancer screening or any screening doesn't prevent disease; it just detects it early. And patients may have personal reasons for wanting to get screened. They may have a fear of cancer, and just knowing that they're okay helps them. It may give them some relief from anxiety. It may give them reassurance that they don't have the disease. And one thing, Reverend Ford, that was really interesting that we have found is that sometimes, unfortunately, a clean screening scan sometimes gives patients an excuse to keep smoking, which is, of course, the wrong effect we want to elicit from these patients. But we have seen a little bit of that. I'll dwell on the side for just a second. We screen patients for cancer once a year, for lung cancer once a year. There are some patients that actually are missed because the disease is so aggressive that within a year it can go from detectable on a scan to being late stage, and that happens in about 3% of patients. And so we missed, even in the screening trial, we missed about 3% of patients, but the majority of them were picked up early. Now, what happens if you get a lung cancer? First of all, what is a lung cancer screen? It's a CAT scan. A CAT scan is basically a three-dimensional X-ray. It's very, 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 very sensitive. It can pick things up that are only 2 millimeters in size. But basically, you go to the scanner. You don't need any IV. You don't need no needles. You basically just lie down on the scanner. It's a single breath hold. It takes about 20 seconds, and you walk out and go home. And usually, we get a result within a day or so, and you find out what the result is and if there are any other recommendations. So there's no discomfort involved. It's very quick. But I'm going to go into some of the risks of screening too. But the rate of a lung cancer screening showing something is about 24%. That's pretty high, 24%. About a quarter of patients have something. But the interesting thing is that about 90% of those things that are found end up not being cancer. So you wonder, well, what the heck? I'm going to get a scan. I'm going to have a high rate of finding something, and then most of that stuff isn't even going to be cancer. So why the heck did I go? Well, 96.4 of them were false positives, which means that it showed a possible cancer, but it's not. Some of those results may generate a follow-up scan or some other type of scan or some invasive procedure, but a lot of them, the overwhelming majority, are just basically adjudicated by another scan down the road. And then it goes away or it stays stable. We don't need to deal with it anymore. So most of the positive results, we just have to get another scan down the road. That can cause problems. It can cause anxiety, but it's one thing that we just have to talk about. And that's one of the risks of lung cancer screening. Why don't we screen everybody? Because it's not just to check under the hood. It can cause problems. So we're going to talk about that. So you have false positive results. We just talked about that. If you get a positive result, it may mean that you need a procedure that can have risk. There's a risk of something called overdiagnosis. There's radiation exposure, and there's anxiety. I will tell you that all of those risks pale in comparison to the risk of not being screened, but I'm going to delve into it quickly. This is a really interesting concept called overdiagnosis. So we're kind of always afraid that the doctor's going to tell us something and he's going to give us some kind of disease, but it's not really important or won't really hurt us. So overdiagnosis is the detection of a cancer that would not cause symptoms within the patient's lifetime. So overdiagnosis doesn't mean we're finding stuff that's not cancer. We're actually finding cancers, but they're cancers that never would have caused a problem. So for instance, someone at age 90 gets found to have a lung cancer that might kill them in 10 years, but they only live to the age of 93. So that's overdiagnosis. Someone who's 60 that gets diagnosed with a lung cancer and then walks outside and God forbid gets hit by a bus. They had cancer, but the cancer never would have hurt them. They have a diagnosis of cancer, but they also have heart disease, and the heart disease has a worse prognosis than the cancer. So that's overdiagnosis, and overdiagnosis can result in unnecessary treatment, morbidity, cost, anxiety, and it probably occurs about 18% of the time. There are also cancers that we will find that grow so slowly that they never need to be taken out or dealt with. So it's hard to know that prospectively. So it's hard to know in 2025 that you find a cancer, but you don't really know that by 2030 that it wouldn't have caused a problem. So we don't really always know that. So we have to be very careful because there are some things we may opt to say, it might be a cancer, but I think the right thing to do is just watch it on the next scan, and that's okay. But overdiagnosis is a risk of screening. It's a risk of any kind of screening for any cancer. There's also a risk of radiation, although the risk is very, very low. In fact, it's lower than taking a bunch of cross-country plane flights. It's lower than a standard chest CT. It's lower than a stress test we do for heart disease. In fact, if you did a study, a 50-year-old female who smoked 30 packs, a pack of cigarettes for 30 years, who underwent 25 years of annual low-dose CT scans, their increased risk of cancer from the scans is less than a percentage point, compared with a 17% risk of lung cancer. Same thing for a man. The risk is increased by just a quarter of a percentage point compared to a 16% risk of lung cancer. So we know that the radiation risk is very, very low. It's not zero, but it's low. There's risk of anxiety. You can get potential adverse effects of just being nervous about your scan. The false positives can happen. You can find things that are incidental findings, something else other in the body. But you know, the results from lung cancer screening, sometimes we say, well, we got to get another scan in a year, and you're like, well, now I'm nervous for a year. So some of that has to be factored in. But what really helps that is just really speaking to your patient ahead of time so that they know what to expect. We actually studied anxiety in these patients, and we find that screening programs that include appropriate counseling may have no significant psychological impact on participants who are free of lung cancer. Obviously, if you find a lung cancer, that causes anxiety. Of course it does. But if they don't have lung cancer, as long as they've been counseled, it doesn't cause undue anxiety. What about cost? This is a very interesting discussion because lung cancer screening costs a lot of money. It's one of the reasons the government has been slow to take it on. And it's why some of the indications for lung cancer screening, we'd like to open up to more patients, but it's difficult because it's an additional $2 billion to our national health care expenditure. Okay. So it costs the government about $2 billion to avoid 8,000 premature cancer deaths. And if you do the math, the additional cost of screening to avoid one lung cancer death is about $250,000. So you may ask, how much is your life worth, right? That's a difficult question to ask the government or insurers to ask, well, how much is my life really worth? How much is the worth of your constituents? Is $240,000 too much? That's an interesting philosophical question. But I would say we're worth more than that. So it makes sense for lung cancer screening, and it also may cost less to treat an early stage lung cancer than it does to treat a metastatic lung cancer. So all that gets factored in. And so the actuaries have a lot of work to do to figure those questions out. And it's certainly nothing we're going to solve today.
Yeah. So let me ask Dr. Ebright. So is lung cancer screening covered under most insurances?
Lung cancer screening is covered now under all insurances to the point where you don't even need to pay a copay because it's screening. And we know for cancer screening, we don't pay copays. So lung cancer screening is in fact covered by all insurances. Now, some of the indications for lung cancer screening may be slightly different from insurance to insurance, but most insurances follow Center for Medicare Services, or CMS, which is your Medicare and Medicaid, and they use the indications that we talked about earlier, which is if you're age 50 to 80 and you smoked about 1 pack a day for 20 years, then you qualify.
Okay. Let me ask you this, because we're talking a lot about smoking cigarettes.
Yep.
And we know that has decreased tremendously, individuals smoking cigarettes. But now what you see a lot of, especially men, smoking cigars. How does that, how do you factor into cigar smoking? Usually if you're smoking cigars, it's usually not every day and you're not smoking 10 of them. Usually it's something that is maybe a couple of times a week or a couple of times a month. So how does that affect your ability or your liability to maybe get lung cancer?
So cigar smoking has been very, very difficult for us to quantify risk with. You have fewer cigar smokers. It's a little more difficult to quantify how many cigars you smoke. As far as cigarette packs, patients usually know, I smoke a pack a day. Cigar, well, I smoked a little bit of it. I left half of it on the ashtray. I took one yesterday. I had one a couple of days before. We know that cigar smoking is not good for you. It's not filtered. We can only assume it's as bad as cigarette smoking, but most patients that smoke cigars are not taking in as much as they are with cigarettes because cigarette smoking is easy. They're doing it constantly during the day. What we also know about cigars, however, is it increases your risk significantly of cancers of the mouth and throat and tongue, much more than regular cigarettes. So we do find in cigar smokers the risk of throat cancer, tongue cancer, cancer of the head and neck, and the esophagus are much more increased with cigar smoking than with those who don't smoke cigars or just smoke cigarettes.
Mm,
But cigar smoking certainly is bad for you, for your lungs as well. And you kind of know that. I mean, those who smoke a cigar know that they smoke a cigar and it's like coming out of their pores for the next day or so. It goes everywhere in the body. Same thing with cigarettes. I can tell a patient if they smoke just by looking at their skin. I can look at their
mm.
lungs in the operating room and I can tell. There's a lot of, you can tell by their voice. So cigarette smoking is bad for your heart, it's bad for your lungs, it's bad for your kidneys, it's bad for your skin. It really goes everywhere, which is why one of those things about lung cancer screening, it really is a teachable moment, especially if you find a lesion. There's nothing like finding something in the lung to convince somebody that they should probably quit smoking, which is why
Yeah.
at Stanford we couple our lung cancer screening program with a pretty robust smoking cessation program. I'm going to
Yeah.
stop sharing my screen because I really don't want to. I think we can just talk at this point.
Okay. So let me ask you about this, because what we see now is a lot with our youth. Couple of things. You see the vapes, but not only vapes, but you also see the hookah. Hookah has become very popular as well. How do those increase your chances for lung cancer, or is there a correlation between that?
So I don't think we know enough about vaping to really give a good long-term answer for that. Um, it is extremely disturbing how vapes are being marketed to children with, fancy like flavors like cherry and strawberry and bubblegum and all of that with fancy colors in these markets. Um, because you know what they're trying to do. They're trading the addiction to cigarettes for the addiction to something else. And the vaping is absolutely addicted. It's got nicotine, it's addictive, and there are chemicals, and there's a lot of chemicals, and you can't regulate them. And you're bringing particulate matter into your lungs. Um, we know that there are certain inflammatory diseases of the lung that are found in many patients who vape. We've heard plenty of horror stories. We have patients that come in with a lung collapse because of vaping. But I think vaping will become the next terrible thing that we find out.
Mm,
And I think a lot of those companies like Juul and so forth, the morality has to be questioned with the way they are marketing to young people. It's very disturbing. So the short answer is we don't know. That they were initially marketed as a way to quit smoking. You're trying to trade in one thing in for another. It's like you want to get hit by a bus or you want to get hit by a car. I'd rather get hit by neither one of them. But we will see. One of our pulmonologists here gives a great talk on smoking and risks of smoking and vaping, and he's also nutrition, and he also happens to be the co-director of our lung cancer screening program. So at some point we can invite him to talk about that.
I don't know
But
what just happened.
vaping is no good. And I try to convince as many patients as possible not to do it. I just had a recent patient in the hospital with 2 lung collapses, and he won't stop vaping to the point where I had to operate on him. I think you're muted to me.
Can you hear me now?
I can, yes.
Okay. How about hookah?
I don't know. I really don't know. I wish I know what hookah is. I've seen it. I've been to the Middle East. I know, but I don't know the risks of hookah. I
Mm,
will say that anything you inhale into your lungs that's not nitrogen and oxygen is probably bad for you because your lungs are not meant to take particulate matter in.
all right. And so let me number one thank you, because even as we talk about this and we see the risk factors of getting lung cancer, and even that we can prevent deaths by a simple scan. As you said, I think you said it takes what,
20
2 3 minutes for the
seconds. 20, 20
20 seconds. 20 seconds, and 20 seconds can go and prolong your life. I know, Dr. Ebright, we only scheduled about 20 minutes for this presentation, and we're past 20 minutes now. This has definitely been a very engaging conversation. But may I ask, do you have any final thoughts or comments on lung cancer screening?
Yeah, sure. I would just say that lung cancer screening hasn't really been in the muscle memory of our primary care doctors, so people sometimes don't have to think. They may not think about it, but if you've been a heavy smoker, ask your doctor. It's all you need to do because we hate missing an opportunity to cure somebody.
Awesome. Well,
Right.
Dr. Ebright, we thank you so much for your time. We thank you for this presentation on lung cancer. To all of those who are viewing this, remember our health is our wealth. And the more we can do to make sure we are healthy, the better we will be in the long run. Listen, join us next month, the same time, same place, as we take on our next topic in our health series. Listen, you guys have a great day. Thank you again, Dr. Ebright, for your time.
Thank you for the invitation. Bye bye.
Bye.